recording. Perfect. Am I recording? I don't even know. Okay. Hopefully I'm recording here. Hopefully y'all can hear me. Let's see if I can get myself stop screen share to see if I'm recording. Okay, it says I'm recording. Hopefully we're going. Sorry guys, I don't want to restart it again and lose my feed. Okay, so moving right along, let's chat about blood and hopefully it's gonna work now. Yay, it works. No, no, it's not. Okay. Why is it not working? Okay, it's just not going to work for me unless I do something strange. Okay, so let's chat about this. Let's make this bigger so maybe we can actually chat more about what we're seeing. Maybe that helps. Okay, so we're just going to do it from this view because I have no idea why it's not working from the other view. All right, so what does blood do? And sorry, this might be now the 7th time I try to record this, maybe. Okay, so blood, heart goes bump, bump, lub dub, blood goes whoosh, whoosh all around. That's the basics of it, okay? So blood, its job is to transport things. It holds on to our oxygen, to our nutrients, and it brings it all over to the cells of our body. It brings metabolic waste to the lungs and kidneys, so we can either breathe it out or pee it out. Same thing, it brings things to the gut, so we can either use it or poop it. And then also transport hormones. So endocrine organs make hormones, and hormones get secreted directly into blood and go around. Blood also helps us maintain our body temperature and helps maintain heat in different areas. If you notice that if you ever work out, that certain areas of your body are warmer because it's distributing the heat and sending it to places that it needs. Blood is also responsible for maintaining our pH. That 7.4 is the physiologic pH of blood, just about 7.35 to 7.45. And what the blood does is it acts as a bicarbonate ion reserve, which means it has basic alkaline abilities to make the blood less acidic. Also helps maintain the fluid spaces in all the rest of our circulatory system. It also offers a little bit of protection via the blood, so it prevents blood loss because there are plasma proteins and platelets that cause your blood to clot. Some people have defects where they can't clot, but for most of us that don't, if you get a little cut, you're going to start clotting and scabbing. Also, blood helps prevent infections because it carries important things like antibodies, the complement proteins, which are, we'll go into a little bit, and white blood cells, which are immune cells. Okay, so what the bloody heck is this made of? So if we were to take blood from your antecubital fossa, which is right over here, yes, I just had to have another screening done on me. You put the blood into the tube, and then the tube gets spun around, and then gravity works its magic, and we get things separated out. So blood is the only fluid tissue in the body. So now that you know that, you can all rest happy, right? But yes, blood is the only fluid tissue. It's a tissue, but it's fluid. And when we spin it down, we can see what it's made of. So the most dense part goes to the bottom, and that's your red blood cells. Erythrocytes are a fancy term for red blood cells, about 45% of the blood. And we're looking at blood levels. That's what we're looking at. We're looking at the amount of red blood cells your body has at that moment. Then we have this little thin layer here called the buffy coat. That's where all your white blood cells live and some of your platelets. And then plasma is the fluid component of your blood, okay? That's where a lot of the lower proteins and other things that you'll find in there, okay? So if we were to take a look at this, at the blood cell, if we were to bring it up on an electron micrograph and tag it with a bunch of colors, this is what it would look like. It would look like these little red donuts and fluffy white balls. You're like, great, doctor, would that really did not help me? So let's look at it at the microscope. So microscope, you're gonna see what it looks like, little pink donuts with a central clearing. There is no nucleus in a mature red blood cell. I'm going to repeat that 17 bajillion times in this lecture. There are no nuclei in a red blood cell that's mature. It gets shed. It's part of its thing. Then we have blood cells, or white blood cells. We have a monocyte here, a lymphocyte, a eosinophil, and some platelets with those tiny little fragments, okay? And then we have a neutrophil and a neutrophil, okay? We'll get into those in just a moment about what they are. So this is time number 742, whatever you want to say, of the part lecture. Erythrocytes have no nuclei. They are biconcave. They look like this. And there's a reason for that, okay? They need to have room to hold on to important things like iron, hemoglobin, oxygen. The nuclei kind of get in the way on that. How do blood cells form? So we learned in bone, then the center of our long bones, mainly we have bone marrow, and bone marrow has all these different cells that differentiate into red blood cells, white blood cells. It all starts from a stem cell. So hematopoietic stem cell or hemocytoblast starts off. Do I want you to know this entire cycle? No, but I think it's important to at least understand that there's a process. So stem cell then through growth factors and a bunch of genetic coding gets committed to a cell called proerythroblast. And then it starts developing some ribosomes. Remember what ribosomes do? They make special types of proteins. And then eventually by phase 3, this hemoglobin, the specialized protein that holds on to oxygen, builds up and boop, comes out the nuclei, okay? The nucleus, sorry, there's only one. And then these are the two terms. Where the arrow is where I want you to understand. So arrow over here, number 1, is a stem cell. The end story is that you have reticulocytes, which don't have nuclei, but the precursor of erythrocytes or red blood cells, and then you have at the end a red blood cell. Okay, so how does our body know when to make red blood cells, right? Is it know by magic? Hopefully not. So when there's 2 little red blood cells floating around the tissue, so red blood cells hold on to oxygen, red blood cells bring the oxygen to places. So when there's 2 little red blood cells to bring the oxygen around, you're going to have what's called tissue hypoxia, which means a lack of oxygen in the tissue. But the other way can happen. So an example is when there's too many red blood cells, it increases the blood viscosity, which means, so over the weekend, I went to the Puget Sound and there was a ton of, seaweed's good for you, but ton of seaweed to try to swim through. And it was really hard because there was so much seaweed that I couldn't get the fluidity of the water to allow me to swim. So that's an example of what happens when there's too many red blood cells. It is too hard for the other things to swim around. And how do we control these? We control these by hormonal controls, which we'll get into in a second, and then dietary requirements. And this is where my naturopathic Dr. Hart shines all over the place, okay? So erythropoietin, EPO. It is the main way we stimulate the red blood cell formation. So homeostasis, you're going to hear a couple terms that are going to sound familiar to that, but homeostasis, remember, that is maintaining a balance, a normal blood oxygen level here. So what happens is that something happened to the tissue where there's not enough oxygen being delivered to it. Either it's loss of red blood cells altogether, hemoglobin is not being made enough. Sometimes there's things called sickle cell anemia and thalassemias where there's defects in how that hemoglobin, which holds on to the oxygen to bring around to the blood, it has a defect and can't really hold on really well. Or there's something that makes the oxygen not available. So an example of that is carbon monoxide poisoning. Carbon monoxide has a higher affinity for oxygen, so it'll kick the oxygen off your red blood cell and replace it. That's why it's so deadly. So something happens, a stimulus happens, and then it sends a signal to the kidney. The kidney then releases erythropoietin. Erythropoietin then signals through the blood to the red bone marrow to make more blood cells. So get more red blood cells. More red blood cells means you have more oxygen carrying ability of the blood, and ta-da, you don't have hypoxia anymore, for the most part. Okay, what do we need for really good, healthy red blood cells? We need just with anything that you need in your body, you need the amino acids, you need the lipids and the carbohydrates. You guys will take nutrition and you'll learn all about that as well. Okay, but for red blood cell formation, we need iron. Now, Dr. Wood, where do you find iron? Iron is mostly found in animal proteins. Dr. Wood, where it happens when you're a vegetarian? That's a question to ask your doctor. That's a question that comes up every single time. There are ways to get iron that are not from animals, but they're not as bioavailable, which means they're not really absorbed as well. But that being said, want to be a vegetarian? Go for it. Just got to find a healthy way to do it. So iron, it's from the diet, and it's mostly bound in the hemoglobin. That's what that hemoglobin, how it looks like a little circle like this, and there's 4 oxygens attached to it. And we need those oxygens to be able, so the hemoglobin is kind of like a taxi cab. And the taxi cab needs to go to different areas to drop off passengers. So the oxygen is the passengers. Oxygen hops on, there's 4 spots available in the taxi, it all hops on, goes to different areas and drops them off. That's exactly what it does. Now, iron, if we didn't bind it with hemoglobin, it would be very toxic to our bodies. And so therefore, if it's not bound to hemoglobin, what if we don't need all that iron that we have? Well, there's other ways to store it. There's ferritin, which is a protein that stores iron, and it's mainly found in the liver. And fun fact is that a lot of times, at least as a naturopathic doctor, I look at ferritin levels because that will tell me more about if a person's prone to anemia, which means low red blood cells, than the actual red blood cell before the red blood cell count can actually tell me that. And then the things that we need to make really healthy blood cells include vitamin B12 and folate or folic acid. Why do we need this? Because we'll get to what mitosis is, but mitosis is cellular division. And the purpose of cellular division, we need to make DNA. DNA encodes for everything. Rapid cell division means that we need B12 and folate to make that DNA so that it'll code the cells about what they need to do to divide. So therefore, these are they're highly they're rapidly dividing all the time, no matter what. Even though it takes 120 days to replace a full red blood cell count, it's still happening all the time. So it's not just 120 days and ta-da, and it's all done. So B12, folate or folic acid, and iron are what you need for healthy red blood cells. Okay, speaking of life cycle of a red blood cell. So 120 days is the full circle from the birth of a red blood cell down to the recycling of it. I won't say death unless it gets fully destroyed. So we know that the kidneys make erythropoietin, goes to the bone marrow to stimulate if we need more red blood cells. When the red blood cells have aged, just like when we age, we kind of our skin starts to wrinkle, we get a little broken down, blah, blah, blah. Bones get weak. So hemoglobin gets broken down too. So we need to recycle that hemoglobin. So hemoglobin that gets broken down to its parts. Globin is a protein. Heme is the center that holds that iron. Heme then can either be broken down to be stored as ferritin, or it can be picked up by bilirubin, which is something that the liver makes to help clear fat out of the body. In very simple terms, we'll get into exactly what it does later, but too much of a lecture right now. And once again, I'm talking so fast that I need to slow down. Okay. All right. So bilirubin then holds onto the extra heme to recycle it by putting it back into what's called enterohepatic circulation. So it gets from the liver to the gut, recycled back up, and then it can start the process all over again. It can build the heme, build the globin, put the two together, and you got hemoglobin. Yep. All right. So what kind of disorders can happen with erythrocytes? And normally I don't really jump into too much pathology, but this is something you will see very often in your practice as a dental hygienist. So two sides of the spectrum. You either don't have enough red blood cells or you have too many. So anemia is when there's too little oxygen carrying capacity. Normally a person will present with really fatigue, very pale skin. Their insides of their eyelids will be really pale. They have shortness of breath. Sometimes they'll have headaches. Sometimes they'll bruise real easily. And then there's 3 different ways that this happens. You either have blood loss where you're bleeding out, or sometimes with women, they have really heavy blood periods and they lose so much blood that they can't keep up. Not enough red blood cells are being produced. Sometimes there's certain cancers or a chronic disease that kind of halts the red blood cell formation. And then we have too many red blood cells being destroyed. So there's something called hemolytic anemia where the body is attacking the red blood cells and they break down before you ever have a chance. Okay. Then the opposite end of the spectrum, we have polycythemia, which is too many red blood cells. So remember that analogy about me trying to swim in the seaweed water the other day. Okay. So most likely polycythemia vera is basically it's bone cancer. And it means that the bone marrow has been taken over by cancer and it's making too many red blood cells. How do we treat it? We treat it with phlebotomy. Okay. Then we also have secondary polycythemia, which is caused by low oxygen levels. So sometimes people, in order to become faster runners or faster bikers, they'll train at high altitude. And why do you ask that? Because high altitude has a lower oxygen level. And you want to have stamina and ability to do aerobics, you want to have more oxygen available to get to your cells so you can keep going. So when someone is practicing at high altitudes, they have increased erythropoietin production. So when they come down to sea level, they have a ton of oxygen carrying capacity and they can go faster and harder. Okay. Also see this in sleep apnea, which you will encounter a lot as dental hygienists. Sleep apnea means that throughout the night, you are not getting enough air into the airway to breathe at night. And you're having low oxygen levels and that will be seen. Okay. Then there's the other part of the blood, the buffy coat, so the white blood cells. Okay, white blood cells, they come in 5 different flavors, and you need to know the abundance, and you also need to know what they do. So there's a mnemonic for that. It's called never let monkeys eat bananas. So neutrophils, lymphocytes, monocytes, eosinophils, basophils. That's the order of abundance. So neutrophils are the most abundant in the blood. Their job is to be the first reactors. So if someone gets cut, someone gets an infection, something happens, neutrophils respond as an inflammatory response first. I will show you a picture of what they look like, and they're really cool under the scope. So that's the most abundant type. When there's a lot of neutrophils and there's other things pointing to infection, that normally means that bacterial infection is present. So when we see a person, when someone's sick, sometimes we run their blood to see if it's bacteria or virus. And if it's a bacteria, neutrophils will be high. So lymphocytes are the next most abundant, and lymphocytes are a type of white blood cell, and they're mainly used for what's called innate and acquired immunity. And those we'll see if someone has a virus. So example, COVID is a virus. We would expect to see very high lymphocytes, not neutrophils, if it has at least been a couple of weeks since they've been exposed. Then we have monocytes, that's the monkeys. Monocytes are specialized, they look like little Pac-Man, and their job is to get activated and to come out and chomp on debris and bacteria or anything we don't want in the blood or in the body. Then we have eosinophils. Eosinophils stain pink. If you remember from the first lecture, eosin is pink, basophilic is blue, purple. Eosinophils have these little granules that stain pink. And they only come out when there's either a parasitic worm invasion in the gut. I know that sounds like a lot of fun. Or it comes out when there's really bad allergies, and a lot of times allergic asthma. I see a lot of my patients have higher eosinophilic levels. And the last one is basophils, which is mainly just it's a histamine bag ready to explode for allergies. They're the least abundant, and if you see a ton of them, we start thinking about cancer or really bad allergic reactions. Okay, so this is what they look like under the scope, and I think they're the prettiest thing ever. Okay, you'll see in the lab, it's one of my favorite things to look for, and it's pretty, and it's kind of peaceful because you sit there and count things. So neutrophils, you can see here on the left. Neutrophils have these multi-lobed nuclei, and they're almost a pink and blue type of cytoplasm. Eosinophils, just like I said, you see those little balls in there? That's all eosinophilic granules. They stain dark pink. Basophils, see how they look different from the other ones? You could actually see the little dark purple granules. Lymphocytes are the smallest one, and most of their nucleus takes up. So you can't really see a lot of the cytoplasm, but you can see most of their nucleus. And then monocytes have this kidney-shaped looking nuclei or nucleus, and it has got pale cytoplasm. So agranulocytes means it has no granules. So lymphocytes and monocytes are agranulocytes. Then you have granulocytes because they have granules in them. So that's the neutrophils, which sometimes you'll hear me refer as polymorphonuclear cells because that's the old school term of calling them, eosinophils and basophils. And just like with red blood cells, everything is starting in, for the most part, in the bone marrow. So we have the stem cell, and do I want you to memorize this? No. Do I want you to have a basic understanding? Yes. Starts with the stem cell, and then these are the tiers I want you to know. So myeloid means that it's going to give you granulocytes. Lymphoid means it's going to give you agranulocytes. And I love this little diagram here because it gives you a good idea of where things are going. Because monocytes get activated and become macrophages, those little Pac-Man things. B cells, certain B cells can become a lot of things, but for this purpose of this part of the lecture, B cells we really associate with plasma cells. Plasma cells make antibodies. So COVID, you think is a virus, so these are going to be stimulated during COVID. They're going to make B cells, and they're going to make antibodies to try to attack that virus. And then you have T cells, which either work on the inside or the outside, and their main thing is to know about is effector T cells, and we'll get that soon. Okay? And just like with red blood cells, sometimes we have too many white blood cells, sometimes we have too low white blood cells. Too many red blood cells can happen in two main instances. Infections. So overall, increase of white blood cells means there's infection. But if the numbers are really high, we start thinking leukemia, which is a cancer of the bone marrow. And then if they're also really high, but we already ruled out the leukemia aspect, then we start thinking infectious mononucleosis, or lovingly referred to as mono, the kissing disease, EBV. Then the other opposite end of the spectrum, we can have what's called leukopenia. Penia means little. So leuko means leukocyte. A lot of times certain drugs do this, anti-cancer drugs do this. And if you're on steroids for a really long time, not the kind that makes you beef up, but the kind that brings your immune system down so you can deal with a chronic and autoimmune disease, that can cause low white blood cell count. And the last part of the formed elements of the blood is the platelets. And the platelets come from what's called the same thing, comes from a stem cell, but it comes from a megakaryocyte. And what the megakaryocyte does at the end, so you see it's actually a cell with nucleus, and then it starts shedding off these little fragments, and those fragments are platelets, okay? Their function is to form a temporary platelet plug that helps seal breaks in blood vessels. So if you got a cut in a blood vessel, the platelets come in, kind of act like putting your finger in a hose so it doesn't, until you can get to the duct tape to make it stop going everywhere. Okay, and the important thing is that circulating platelets are inactive and mobile, but and they're mobilized by two things: nitric oxide and prostacyclins, which are a type of inflammatory chemical messenger. And this is what happens when the inside of your blood vessels get destroyed or get hurt. So good table right here is seeing all the different formed elements that we chat about. So this is a great study tool right here. And then we're moving on to the next part. So remember how I said homeostasis is a term you need to know. You need to know hemostasis. So this is a common question that students, whatever you guys are, not patients, not kids, students get wrong in tests because homeostasis and hemostasis look the same, but they're completely different things. Homeostasis is to create balance. Hemostasis is to stop bleeding. So hemostasis. Look out for this one on a test. It will be a question there on purpose to make sure you're reading. Okay, so hemostasis requires a bunch of really fast reactions to stop a bleeding. Because if we think about it, if we're bleeding and we had to stop fast, we'd just bleed out and die. Or become vampires or something, I don't know. So there's 3 steps that are involved. We have this thing called a vascular spasm, a platelet plug formation, which is what I was telling you about, the platelets coming in and putting like a patch on that hose, and then coagulation, which is the actual blood clotting. So events of hemostasis, I do want you guys to know about this. We have a vascular spasm. So something happens to the vessel and it nicks itself and gets hurt. So what ends up happening is that the smooth muscle knows this and it goes, ear, tries to stop it, ear, gets constricted. By constricting, what it's doing, it's actually encouraging platelets to come up. It's sending out chemical messengers to encourage the platelets to plug formation to start. So platelet plug, it's putting the finger down on that hose until you have a chance to put duct tape or whatever real stuff you're going to put on a hose that's going out. So that being said, then once the platelets start sticking together, they have a platelet party and they go, hey, platelets, we're all hanging out together. Let's release some chemicals out and invite more friends. So more and more platelets come together and aggregate. Aggregate means coming together. Now what happens? You coagulate. So we aggregate and then we coagulate, which means that there's certain proteins like fibrin and collagen that get set down and make cement. So we close up that hole and allow it to scab and heal, okay? As part as coagulation is going, we have 2 different pathways that occur. We have something called the intrinsic pathway, which means that something has happened within the blood. So the clotting factors are within the blood. This is normally something like you had atherosclerosis or something, and something inside the vessel goes off. It's not something that happened in the outside world, but something happened in the inside of your body. Extrinsic is the opposite. It's a trauma that occurred on the outside that's causing a different factors to be secreted. So here, do I want you to memorize the entire factor pathway? No way. But I want you to have a basic understanding. So the intrinsic pathway is when the vessels of the endothelium, or the actual little capillaries and vessels, get hurt. Causes this entire cascade of different kinds of cofactors that then eventually lead to what's called prothrombin, and prothrombin then makes a clot, okay? But in the extrinsic pathway, there's cell trauma, there's tissue cell trauma. So it's not the vessel, but the tissue cells, something happened. It excretes out tissue factor. And tissue factor then signals a different type of cascade pathways. So we have some calcium that once tissue factor is secreted, calcium comes in. Calcium activates this, it's called factor 7. And factor 7 comes in, and it does start this other pathway here where we have a whole entire complex, but it also goes towards the other direction, which is intrinsic. In the end of the nutshell, what it's doing is making clots. And what do we need for proper clot formation? And this is going to hint, hint, nudge, nudge. You will need to know this, is vitamin K. Vitamin K is an important cofactor in getting all these different other cofactors where you're seeing the numbers to get activated. So yes, calcium is here, but the main thing I want you to know about is vitamin K. So when newborns are born, they get a vitamin K injection. Why is that? Because we want to make sure they have the ability to clot, because sometimes when newborns are first born, they don't have all their clotting ability, and it's much easier for them to bleed out. So vitamin K helps helps clotting. So that becomes an issue. Say you're in the chair and someone told you that they're on Coumadin or warfarin and you're about to do dental surgery with your dentist or clean a tooth, and you need to know if they're going to stop bleeding or not. That is important for you to know, because if they're on Coumadin or warfarin, then we need to make sure, one, that tells us that they have thinner blood and they may not have the ability to clot. And two, from a physician standpoint, I have to monitor that they're not getting too much vitamin K to affect their clotting abilities. And then there's a couple of disorders of hemostasis that you should know about. So when something gets clogged in a vessel, it's called a thrombus. So basically the vessel's not broken, but a clot appears. So example is eating tons of sugar causing atherosclerosis, which is cholesterol lining into your vessels. That causes these hard plaques, and then hard plaque causes tear in the inside of your vessel. What happens when the vessel tears? Vascular spasm, platelet plug, coagulation, and then a clot forms. That clot can get stuck. It can get stuck if it gets big enough. Sometimes it just heals right over, but sometimes it makes a giant clot. Typically, we see these in the deep veins of our legs. This can block circulation and cause tissue death. So a lot of times you can actually lose a leg if you have a really big thrombus. What's even a more medical emergency is when this thrombus, because of the turbulence of the blood, shoots the thrombus off of the vessel, and now it's being free floating in the bloodstream and can get stuck in any place it wants. Most deadly places are in the pulmonary arteries, which is where you supply your lungs, or in the brain for the cerebral. So that's stroke and pulmonary embolism. So those are things we need to look out for. And then I'm sure you guys have heard it, but I'm going to say it again. So there's blood groups. Our genetic code for each of us are different, and each of us have a blood group. We have main blood groups that we're going to talk about, and believe it or not, there's like 40 different blood groups. So we're only going to talk about the main ones to get an idea. It's called the ABO blood groups. And what they stand for is that the ABO stands for an antigen or so a glutinogen means the same thing as antigen. Glutinogen, I'm going to refer to as antigen because I'm going to keep butchering the name every time I try to say it. So type A blood, so I'm a type A. Type A blood has type A antigens, which means that if anything else comes out that's not recognized as type A, I will make antibodies against it and fight against that blood. Type B, same thing. Type B has B antigens, but has anti-A antibodies. Type B has A and B antigens, so guess what? No antibodies. It is the universal recipient. It can receive blood from anyone because it doesn't make antibodies that are going to affect anything. And then type O is a universal donor because they don't have any antigens on their surface, which means they don't stimulate an immune response. Okay? So in a nutshell, in case anyone was confused about this, AB is a universal recipient. Type O is a universal donor. Why? AB has all the antigens on it, so it's not going to be able to have any antibodies. Type O, universal donor, doesn't have any antibodies, so it can't stimulate an immune response, but it has, because it has no antigens, but it has the antibodies, so it can't get it from anyone else. It has to be type O. And how do we tell this under a microscope? What we do is we do blood typing and we see what coagulates, and that's how we know their blood type. Okay, that's it for blood. I'm going to hopefully have this recorded and uploaded, and I'll see you guys in the next lecture set.